the lights would go off anytime. And I remember clearly when we operated, my boss was a thoracic surgeon, and we did a lobectomy, a difficult operation of chest with no lights. The lights went off, and we worked with 2 powerful torches for 3-4 hours. We did the whole operation, closed the chest, and the lights came. And we sutured the skin under bright lights. From there I came to Mangalore. Mangalore was a small district place. Lots of patients, lots and lots and lots. Very advanced diseases, but awful conditions. One operation theatre, 2 tables in the same room, no air conditioning, no changing of clothes, and we operated. The sweat going into the wounds was prevented by a ward boy who would mop us now and then. An occasional fly, I always prevented it from getting into the wound. But under those circumstances, we operated. And then we came to Goa. Goa was a new medical college. My particular hospital was 8 kilometers away from Panji. So the blood bank was 8 kilometers away, and the equipment I had was only about 17 artery forceps, a half-working cautery. If I wanted a blood urgently, I would take at least 2 hours to get 1 bottle of blood. But even under those circumstances, I could manage. We operated, we did anything and everything, and lo, our results were excellent. In Goa, I had less than 1% mortality, of which 60% was emergencies. So if I were to take the routine operations, then my mortality was less than 0.4%. And therefore I realized that we need not have a lot of equipments. We can work without much cost and we can give results. And that is what prompted me towards the idea of doing maximum with least cost, with least equipment. I was in a way fortunate or unfortunate that I had an influence during my college days of Gandhian and socialist thoughts. And that also prompted me to the same thought that how we can deliver the services to the patient without incurring a lot of cost. But cost effectiveness does not mean cheap treatment. The cost effectiveness must have the same answerability as any other treatment. So only if our results can compare, despite the low cost, with the results in the average place, then only we can call it as a cost-effective management. So cheap management is not cost-effective management. The results must be comparable. If there is a very small improvement with a very high cost, it is not needed. But on the other hand, if the low cost gives you a poor result, that is not cost-effective management. So remaining rigid to this definition that cost-effective management must give at least comparable results, maybe a little more morbidity, maybe a slightly more mortality, but a comparable result, then that's not an easy task. It requires deep knowledge of the pathophysiology. It requires very sound clinical observations. We are nowadays not even watching the patient, not even seeing the patients, but I had some teachers who taught us, even without talking. Dr. Grant would tell us to just watch the patient and tell us what is the diagnosis. Just inspection and palpation. So if you take full history and full this, then only you can do this sort of a job. The third thing required is an extremely dexterous hands. And you must continuously try to improve your skills. Because as I said, if I don't have a bottle of blood, I can't depend on it. Then I have to be very careful that I don't lose blood. And therefore, you require a lot of this. And to prove that it is cost effective, I must have good records. And I must also have cost consciousness. So when I came to Bombay, I continued with that effort because that was my obsession. Not that I could not have asked for many equipments, but I didn't ask for a lot of equipments and things. And I worked, and I found I did a lot of things. The most important, I'm just putting some of them. We get about 1,000 cases of head injuries in Sion Hospital every year. So these unconscious patients are to be treated. I had a peculiar, of course, based on the proper pathophysiology, I had an extremely simple management principle in this head injuries, with which we had results. Decerebrating patients have 80% mortality in the world literature. I had 70 to 75% mortality. And I had no equipments, no ventilator, no blood gases, nothing. So, going deep into the pathophysiology, managing the case, avoiding respiratory complications, we were able to do this. These patients require tube feeding. And tube feeding, there is a formula we get in the market. You take a packet, put it in the milk, and you get about 250 to 300 calories. If you have to give full nutrition, you have to give at least 6 packages. That comes to 800 rupees. 7 to 800 rupees per day. Whereas we evolved a formula with sugar and salts, milk and things, blended rice diet, which costs hardly 60 to 70 rupees even today, and the patient can be managed. One of my patients, she had acid poisoning, and we had to put tube feeding, and it took 2 months before she became a little better, and we wanted to do a colonic replacement for the esophagus. And we found that she was pregnant. So I told her that you continue with this tube feeding because this is simple, you can afford at home. She continued. She continued feeling from 5 months of pregnancy. She came to full term, she delivered, and she breastfed, all with the tube feeding, which a very common lower middle class person could afford. And after that, when the child was 6 months old, we operated her and put her esophagus. I treated burns. I will not go into all the details. But about the antibiotics, the marketing is very peculiar. The market does what? It tells us, I will not go into the, she has been in the research one with pharma. They tell us to give the maximum dose. Their own literature shows that the minimum inhibitory concentration is here. But they will say that this drug is safe, and even if you give this much dose, it has no side effects. I asked them, but why should I give this much dose? If this is the killing dose, why cannot I give a smaller dose and still cure? They had no answers, but I knew the answer. The answer is market. Well, but why does it not become popular? Mainly because it is a very aggressive market. The market is so aggressive, it pushes technology, it pushes medicines, it pushes everything. And to fight this market is almost impossible. So whatever you do, we're likely to be lagging behind. Number 2, which is a very real one, is the fear of litigation. Even small mistake, the press and the this one and the legal, everyone will bounce. There can be 10 cases dying with all modern things, but one case dies without modern things, you are hanged. And that is the fear which the doctor naturally has. As I said, media trial, good for the people, but it is not good for me. And therefore, we don't like to go into that line, and we take a safer line of doing more investigations, using high tech, becoming protective, and give costly treatment. Well, I may have some sympathy for the patient, but I have more sympathy for myself. So, how do we counter it? I don't know. These are all the thoughts I have. One is that technology is marketing very heavily. Yes. Could we go to the smaller technologies and induce them to market the easier methods of treatment? Can we get the political and media support